Please unmute yourself. Please unmute yourself.
Hello, ladies and gentlemen. Good afternoon. Thank you for the kind words. I'm an endocrinologist practicing at Apollo Hospital, Jubilee Hills, Hyderabad. I've been asked to speak about sexual dysfunction in diabetics, as it is not possible to speak about sexual dysfunction in both men and women in a span of 20 minutes. I've chosen to speak about sexual dysfunction only in men. So if you go back in history, this condition of erectile dysfunction has been elaborately described as klaidya in the Ayurvedic classics. Charaka has mentioned it as daurbalya, which is a complication of madhumeha. If you look at sexual dysfunction of in diabetics, I would like to emphasize that there are many forms and shapes, and I would like to dwell on these in the form of 5 clinical cases, alluding to real-life scenarios and learning points in each scenario. Case 1 is that of a 36-year-old plumber, type 2 diabetes for 2 years, A1C 6.4 on metformin, no hypertension, lipids in target, non-smoker, and doesn't drink any alcohol. He's single, planning to get married, concerned about sexual dysfunction. On careful history taking, it was obvious that he does have premature ejaculation rather than erectile dysfunction. His libido was good, and erections during the morning time were fine. We have given him a trial of SSRI, and at 1 month's follow-up visit, it was found that he felt that the medications were useful. He presents after 6 months later saying that he needs help again. Apparently, he used SSRIs for 3 months only, but wanted better performance, even better than what he was having after the SSRIs, and seen another doctor who stopped SSRIs and started testosterone injections as suggested by the other doctor. At this current juncture, his tests revealed that A1C was still not bad, 6.6, testosterone 3 times above normal range, low LH and FSH, oligozoospermia, hemoglobin was elevated at 17.2, as was hematocrit, and fortunately he has had normal LFTs. Review of the reports prior to starting testosterone showed that his testosterone was in the lower end of the normal range, but not really low. His calculated free testosterone was not actually assessed. So he's been counseled and asked to stop the testosterone. SSRIs were restarted. And after 3 months, after stopping the testosterone, he's married now, his sexual life is good, and all the above tests normalized. So what are the learning points? If you look at sexual dysfunction in men, it can be due to erectile dysfunction, it can be due to low libido, it can be due to ejaculatory disorders such as premature ejaculation, delayed or retrograde ejaculation, or lack of orgasms. These should not be confused, because erectile dysfunction and premature ejaculation can coexist and usually confused. Testosterone unwarranted prescriptions are common and do more harm than good. Side effects of unnecessary testosterone usage could be gynecomastia, low sperm count, increased hemoglobin, i.e. polycythemia, suppression of endogenous testosterone production. It can lead to acne and greasy skin, deranged LFTs, and of course prostatomegaly as well. Few words about PE. Premature ejaculation is also referred to as rapid or early ejaculation, and is now defined as male sexual dysfunction, which is characterized by all of the 3. Remember, the patient needs to have all 3 of the below. Ejaculation that always or nearly always occurs prior to or within approximately a minute of vaginal penetration. Some suggested that this time needs to be increased. Either present from the very first sexual experience or following a new bothersome change in ejaculatory latency. The person should also have inability to delay ejaculation on all or nearly all vaginal penetrations. And this should lead to negative personal consequences such as distress, bother, frustration, and or avoidance of sexual intimacy. So one needs to fulfill all this. So changing the gear, let's go to case 2. 52-year-old self-proclaimed spiritual guru, obese, BMI 42, type 2 diabetic for 5 years, A1C 7.3, controlled hypertension, lipids within target. On metformin, ARB, statin, aspirin, non-smoker, no history of alcohol usage. Married, has a teenage daughter. Erectile dysfunction for several years, no libido whatsoever, no early morning erections. Spoke to his family physician tried sildenafil with little benefit. He developed atypical chest pain eventually after a few months, has had non-specific ECG changes, was admitted in our hospital for coronary angiogram, which was normal. Then he disclosed to his cardiologist that he does have erectile dysfunction, and the cardiologist referred to us. The patient has been seen in the OP, and tests showed that he does have 20 times elevated more than the normal range. Testosterone levels were low. Calculated free testosterone was low. FSH and LH were low. TFTs and other pituitary profile were normal. MRI did show an adenoma, 1 centimeter roughly in size. He's been counseled and started on cabergoline, 0.25 micrograms twice a week. He's been asked to come after 2 months, and then his prolactin was normal. His calculated free testosterone, FSH and LH were normal. And he says that, doc, I'm now unable to control my urges. That's a new complaint. So learning points. Hypogonadotrophic hypogonadism can be seen in prolactinoma. Sorry about the typographical error. Decreased energy and libido are common in the long term. Decreased muscle mass, decreased body hair and osteoporosis. ED can occur by a mechanism unrelated to hypogonadism though, and treatment is definitely not testosterone but normalizing prolactin levels. It can also lead to infertility in men, probably by decreasing LH and perhaps FSH secretion. It can also lead to galactorrhea, although very rarely. As I said, treatment is cabergoline, and it reiterates the importance of good history taking because not all cases are straightforward erectile dysfunction just because of diabetes. Case 3, 32-year-old erectile dysfunction since wedding few weeks ago, seen a sexologist. Test showed low normal total testosterone. No SHBG has been checked whatsoever. Normal TSH, no FSH or LH were checked. A1C 6.2, fasting sugar 101, random sugar 158. And he's been started on testosterone tablets, sildenafil, multivitamins, alternative medicine supplements, and metformin by these so-called sexologists. And he's seen another sexologist as well, and he has been prescribed similar cocktail. He presented to me after about 6 months after all this, and by then his hemoglobin and hematocrit were in the upper end of normal range. Testosterone was slightly above the normal range, LH suppressed, FSH normal, LFTs normal, and slightly low sperm count. Examination was normal in terms of virilization, and testis size was normal. I retook the history, and when I took the history, it appeared that he did have sudden onset erectile dysfunctions since his honeymoon. He did have performance anxiety. So we reassured the patient, counseled the couple, stopped all medications, reviewed after 3 months when the testosterone, LH, hemoglobin, and hematocrit were all normal. We reassured them again and reviewed after 6 months. And in his own words, no more erectile dysfunction. Wife is now 6 weeks pregnant. Learning points: performance anxiety is common. It is usually sudden onset. It's important to take simple history taking and reassure the patient and counsel the patient. Case 4. Couple from a well-to-do business family. Wife enters the room along with the husband saying, "My husband has erectile dysfunction. Please help doctor." The 35-year-old businessman has an A1C of 5.9, not on any medications, normal blood pressure and lipids, not on any medications whatsoever. Married for 8 years, 5 years old child, harmonious marital relationship, seen urologist, was reassured as normal by the urologist. But they came to me for second opinion. Husband, when he entered the room, had drooped shoulders, low self-esteem when he entered the consult room. And upon detailed history, it was revealed that the patient has normal libido, normal erectile dysfunction, and coitus lasts good 5 to 6 minutes. Further history from the wife, it appeared that the patient's wife, i.e. the one who actually brought the patient to me, has lost her mother a year ago, has low mood, no orgasm since, and we had to reassure the husband and refer the couple to psychiatrist for wife's depression, because here the problem is with the wife and not with the person, which is the man. The husband leaves the clinic room with upright shoulders and with a smile on the face. Learning points: erectile dysfunction is defined as a consistent or recurrent inability to acquire or sustain an erection of sufficient rigidity and duration for sexual intercourse. Remember, female sexual dysfunction exists and you can't blame the man always. Interviewing the couple can be helpful, and we need to understand that sometimes there can be a mismatch between reality versus expectations. Last but not the least case, 55-year-old type 2 diabetic, hypertension, ex-smoker, ischemic heart disease, PCI, i.e. stented 2 years ago, does not open up with the family physician for help, but he suffers from low libido and erectile dysfunction. He buys an aphrodisiac herbal cocktail from the net and medications by a local quack who claims to be a sexologist. He presents to me to my OP with complaints of headaches, dizziness, and low blood pressure of 88/58. Test showed that testosterone was elevated 3 times upper end of normal, low LH, hemoglobin and hematocrit were elevated, and normal LFTs. The aphrodisiac herbal cocktail perhaps contains sildenafil, testosterone, and God knows what other medications. Drug interaction of sildenafil with nitrates is the most likely reason as to why the patient had low blood pressure, and the hematocrit is elevated obviously because of the testosterone. Beware of designer drugs, herbal remedies, counterfeit medications, and it is very important that we facilitate our patients to open up, or else they end up with quacks. Let us look at designer drugs in herbal aphrodisiacs. 1/3 to 1/2 of supplements claiming to be natural products, i.e. herbal remedies or whatever, which are sold in the form of sexual enhancement medications, do actually contain sildenafil or analogs. The concern is that patients who take nitrates for cardiovascular disease may experience a drastic lowering of blood pressure if these supplements are consumed. There is an FDA warning as well not to purchase or consume dietary supplements that claim to increase sexual stamina, confidence, and performance, and are claimed to contain prescription strength doses of sildenafil or tadalafil. Counterfeit medications can kill. WHO reported in 2008 that 1/3 of the counterfeit medication involved the genitourinary therapeutic area. In 2006, it was estimated that between 0.2 to 2.5 million European men were possibly exposed to illicit sildenafil, compared with 2.5 million men using legal sildenafil. So quite a significant number. This is an article published in Times of India on 1st of August 2021. Whale vomit to lizard penis, trade in wildlife Viagra gets savvier. So people have been buying weird, wonderful products over the internet and physically as well. And if you look at the other side of the coin, the association of exercise with both erectile and sexual function is pretty good. So if somebody were to exercise regularly, then they have better erectile function and sexual life. So this is one good reason to ask your patients to exercise regularly, so that they would have good erectile function as well as sexual life, along with good glucose control, blood pressure control, less risk of heart problems. So on that note, let me summarize that there are a lot of problems in our patients with diabetes, erectile dysfunction, ejaculatory problems, lack of libido being some of them. Remember, erectile dysfunction is a symptom, a rather distressing one for the patient and the partner. It is important to take a good history in our clinic. Not all sexual dysfunctions are erectile dysfunctions. It may or may not be male sexual dysfunction after all, and the patient may not need any medication at all. Do consider diagnosis other than diabetes as cause of sexual dysfunction, even in diabetics. Beware of quacks, the internet, herbal cocktails, illicit and counterfeit medication. On that note, thank you very much for your patient listening. Thanks to RSSDA for giving me this opportunity.